In this presentation, we are going to show the results of a specific research activity conducted in Italy about home care workers exposed to biomechanical risk, and we can see findings about incidence of work musculoskeletal disorders in exposed workers and unexposed subjects in the same territory. Initially, from a review of literature on methodology for analysis of biomechanical overload in this sector, we can see a lack of methods due to the high variability of services. But from literature we can see the main risk factor that are manual patient handling, awkward shoulder posture or for shoulder or spine, inadequate space and furniture, that is home, different home space, lack of equipment, and the presence of only one home care worker. In this slide we can see prevalence of work musculoskeletal disorders among home care workers in literature. Since 1993, the home care sector has received attention due to high prevalence of work musculoskeletal disorders. The same in 2017 from Carneiro, that compared hospital workers to home care workers and have like result 3 times much high lower back disorders in home care workers. Another aspect more important is Myers and Silverstein in 20 and 2 that demonstrated an high incidence rate affecting the 46% of operation each year, about shoulder and lumbar injuries combined. That is more important. The research project in collaboration with the country in Italy have meetings with employers, trade unions, local health authorities. 3 companies involved in the project, and organizational aspects were described by coordinator responsible for managing workers. So we can create the first checklist to collect risk data tailored to individual operators. The first aim of the research was identify risk assessment methods for home care workers, and the second was establish fundamental guidelines to use ergonomic equipment to reduce the risk. For the first aim, identification of risk quantification methodology, we conducted a preliminary pilot risk assessment, followed by numerical expansion to include a larger workforce. We have also a web-based platform equipped with specialized software for risk and clinical data management and contemporary assessment of work musculoskeletal disorders in nurses, aides, and unexposed workers. Each worker was required to complete a checklist for at least 7 consecutive days, with some information about organizational aspects of the day, of the shift, the type of patients they cared for, and the activities performed. Quantification of patient lifting tasks during home care activities of the specific shift in that day, and furniture and spaces used to provide home care, and also specification of equipment that was available. The criteria employed to elaborate data about risk was for manual patient handling, overloading tasks affecting the lumbar spine, shoulder and knee have been defined in literature by bioengineering studies, but from Garg to Maras, Jaeger, and so on. For the task performed using non-adjustable furniture or furniture with a height fixed at less than 70 centimeters, we have task duration and minutes spent in an awkward posture affecting lumbar spine or shoulder. In a work area in which it's not possible to shoot footage, to confirm adequacy of criteria about awkward postures in respect to the height of furniture, of fixed furniture in the home care, we simulate activity with a worker below 158 centimeters of height and furniture less than 70 centimeters. For the simulation we use a toolkit Xsense suite equipped with a reflective marker and relevant software to assess postures involving biomechanical overload during different work activities, and respect of awkward postures, we note the postures of spine and shoulder in 3 direction of the space, like a footage. An instance of simulating activities involving bedside hygiene and patient dressing for total non-collaborative patient at 65 height of the bed by a worker not too high, and the frame confirms the assumption of awkward posture affecting the lumbar spine and the shoulder, so confirm criteria used in the research. The data related to home care activities carried out in pilot group and second phase of detection was about 56 workers over 364 workdays to a total of 2,363 patients that were processed. So we can quantificate risk factors based on activity performed and type of patient. And the aim was to extend the application of methodology to home care in relation to number of patients assisted in the shift, type of patients and type of activity. This slide shows some results. 77% of the patients are to be lifted because they are or total non-cooperative patient or partially cooperative patient. In home care, the activity are carried out by a single worker. We can also note the high weight of the patient that have to be lifted. The aids provided to care for the 1,847 total non-cooperative patients was only 20% of listing oils and only 4% of height adjustable bed and a few shower chairs but not adjustable in height. The activity processed about 2,363 patients is beneficial for estimating risk when it's possible to reconstruct a typical day of activities carried out by healthcare providers for their patients. The most frequent activities carried out was four. The first, bedside hygiene activity for total non-cooperative patient, and the second for partially cooperative patient. The third, hygiene activity in bathroom provided to partially cooperative patients, and the fourth activity provided to a cooperative patients. In this slide we can see the risk involved in bedside hygiene activities. All the data for the four activities we can see in last slide are elaborated like data in the same mode, with the frequency of overloading tasks per operator to care for a patient, and with a box plot that show us the mean and the median of overloading tasks that confirm the adequacy of these data about risk in home care workers. In this slide we can show that for this activity we have for partially cooperative patient 6 like frequency of overloading tasks and 8 for total non-cooperative patient. The findings that emerged for each activity is this. For bedside hygiene activities of total non-cooperative patient, 33 minutes like average time, total of overloading tasks 8, 33 minutes spent assuming awkward postures affecting lumbar spine and shoulder due to the lack of adequate furniture. Lifts, when available, used for 41% of tasks, bed to wheelchair or vice versa. The same typology of results we have in all the other activity like bedside hygiene activity or hygiene activity for partially cooperative patient conducted in bath or activity conducted to total cooperative patient. In this slide we see the cumulative load induced both by frequency of overloading tasks and by the absence of recovery days in this particular worker, and by the assumption of inadequate posture for the spine in height and for the shoulder. We can see also activities provided to cooperative patients, that is average time spent at home of like 39 minutes. Standing monitoring is performed for 60% of patients with an average time spent assuming awkward posture to the shoulder of 23 minutes. Hygiene of 29 patients on the other hand is performed in a fixed shower chair with incongruous spine posture for an average time of 33 minutes. Due to inadequate furniture, providing care to cooperative patients also causes the assumption of awkward posture affecting lumbar spine and shoulders in the workers. To sum up results, we see in the slide that risk estimation can therefore be obtained by reconstruction the typical work day taking into account the following aspects: length of shift, total number of patients cared for in the day, number of total non-cooperative patient and partially cooperative patient, type of activities provided to total non-cooperative and partially cooperative patients. By associating the above-mentioned aspect with the risk, it became possible to estimate the risk of nurses' aides experiencing biomechanical overload as frequency of overloading tasks, an aspect that involves spine, shoulder, but also knee districts. Time spent assuming awkward posture detrimental to the lumbar spine and shoulder. The study of cumulative load requires analyzing an entire work week of the same operator. The solution for risk reduction is based on the previously reported data and the associated specific risk, and the following action can be proposed. Organizing a shift schedule to ensure that cooperative patients are included in each shift, and to ensure also that in the week there is the presence of recovery days. Providing aids that are suitable for environment, type of patient and activity, considering performing home care with 2 caregivers for total patient and non-cooperative weighing over 100 kilograms, providing 8 adjustable beds in the presence of both total non-cooperative and partially cooperative patient. Clinical findings of the research cover exposed and unexposed workers and were collected in the same period and territory. Number of nurses' aides were 116, and number of unexposed workers, administrative workers, were 62. Let's have a look at the same data regarding musculoskeletal disorders of that workers. In this slide we show clinical outcomes across the total number of exposed and unexposed subjects, and almost all the comparisons between exposed and not exposed have shown a high significance, especially for diseases of the lumbar spine and shoulder. Particularly for lumbar spine, the subjects who have suffered with at least one episode of low back injury in the last year was for nurses 32% and unexposed worker 14%. Lumbar disc herniation with scans for nurses' aides was 21 or 22%, and unexposed 7 or 8%. In this last slide we can see findings of the research. The risk of experiencing biomechanical overload in the lumbar spine and shoulders is mainly determined by the frequency of overloading tasks and maintenance of awkward postures over an extended period of time. Two important factors about specific risk. Further research is being conducted in other regions of Italy to validate the data on the prevalence of work musculoskeletal disorders and associated risk. Guidelines for biomechanical overload risk reduction in home care have been developed, and clinical data about home care workers and unexposed workers showed high significance for almost all parameters analyzed. With this slide, I just want to thank you all for your attention.